Good morning everyone, I am Amira Pauline Fenol of Group 6 and today we will discuss about senile cataract. Senile cataract is an age-related vision-impairing disease characterized by gradual progressive clouding and thickening of the lens of the eye. It is the world's leading cause of treatable blindness. A patient with senile cataract often presents with a history of gradual progressive deterioration and disturbance in vision. Such visual aberrations are varied depending on the type of the cataract present in the patient. Decreased visual acuity is the most common complaint of patients with senile cataract. The cataract is considered clinically relevant if visual acuity is affected significantly. Furthermore, different types of cataracts produce different effects on visual acuity. For example, a mild degree of posterior subcapsular cataract can produce a severe reduction in visual acuity with near acuity affected more than distance vision, presumably as a result of accommodative meiosis. However, nuclear sclerotic cataracts often are associated with decreased distance acuity and good near vision. Another common complaint of patients with senile cataracts is increase in glare. This complaint may include an entire spectrum from a decrease in contrast sensitivity in brightly lit environments or disabling glare during the day to debilitating glare with oncoming headlights at night. With these chief complaints, a complete ocular examination must be performed beginning with visual acuity for both near and far distances. Examination of the ocular adnexa and intraocular structures may also provide clues to the patient's disease and eventual visual prognosis. Slit lamp examination should not only concentrate on evaluating the lens opacity but the other ocular structures as well, such as the conjunctiva, cornea, iris, and anterior chamber. Corneal thickness and the presence of corneal opacities, such as corneal guttate, must be checked carefully. Appearance of the lens must be noted meticulously before and after pupillary dilation. The importance of direct and indirect ophthalmoscopy in evaluating the integrity of the posterior pole must be underscored. Optic nerve and retinal problems may account for the visual disturbance experienced by the patient. Furthermore, the prognosis after lens extraction is affected significantly by preoperative detection of pathologies in the posterior pole such as macular edema, retinal dystrophy, optic atrophy, severe glaucoma to scupping, and age-related macular degeneration. Also, in the retinal periphery such as retinal breaks or extensive vitreoretinal traction. At present, there is no time-tested, FDA-approved, or clinically proven medical treatment exists to delay, prevent, or reverse the development of senile cataracts. The definitive management for senile cataract is lens extraction. This includes phacoemulsification and manual cataract surgery. Phacoemulsification has become the most preferred method for cataract extraction. Phaco requires complex machinery to break up the lens nucleus and remove it through a small incision. The vast majority of cataract surgery is performed under local anesthesia. During a cataract surgery, a small opening is made at the side of the cornea. In here, a pen-shaped instrument is inserted through the opening to reach the lens. This instrument uses a special type of energy to break up the center of the cloudy lens. Then, it will carefully suction out the lens pieces. An artificial lens is then inserted, called an intraocular lens or IOL. This IOL will stay in the eye permanently. The new lens lets light pass through and focus properly on the retina, bringing back clear vision. Manual cataract surgery is an effective alternative to phacoemulsification in countries where very high volume surgery with an expensive instrumentation is required. A self-sealing partial thickness scleral tunnel is dissected and the anterior chamber is entered. Next, capsulorhexis is performed. Hydrosection or injecting water between the cortex and the capsule to separate structures is performed and the nucleus is partly prolapsed into the anterior chamber. A small hook is inserted between the posterior capsule and the nucleus is extracted. It is also possible to extract the nucleus with an irrigating vectis. The epinucleus and the residual cortex are aspirated with a Simcoe cannula and the interocular lens is inserted. After cataract surgery, medical therapy is used post-operatively to ensure subsequent visual rehabilitation. A non-steroidal anti-inflammatory ophthalmic such as Nepafenac ophthalmic or Nevanac is used for pain and inflammation associated with cataract surgery. A number of topical antibiotics are used depending on the surgeon's preference, but generally, medications are active against both gram-positive and gram-negative organisms. Such antibiotics include fortified vancomycin, ceftazidime, or bacitracin. We also give topical mydriatics such as atropine 1% twice a day daily to dilate the eye to minimize movement of the eye to decrease pain felt by the patient. So that's the end of my discussion. Thank you for watching.